COVID, but now we are out of that. But the obesity pandemic was before that, and it is still there. There are various ways to control obesity and for the weight reduction. The common examples are like calorie restriction, exercise, bariatric surgery. But people are always looking for an option which does not have, in which they don't have to work hard. And for that reason, the options of medicine or a drug is always very attractive. Recently, a new molecule has been available in the Indian market, which claimed to be very, very effective. It said that it can reduce weight by 20%. So a lot of people ask us a question that should we use it? And that questions made us to think about this webinar. And then we are very fortunate to have two experts of India to participate in the discussion. Dr. Urman Dhruv is our first expert. He is a physician, diabetologist practicing in Ahmedabad. He is the director of internal medicine department at SCG Medisurge Multispeciality Hospital in Ahmedabad. He is well-read and up-to-date in his knowledge. His YouTube channel of lifestyle diseases are very popular. A lot of people, they get information, the current recent medical information from that webinars. He is also Bachelor of Law and has a very thorough knowledge of medical legal aspect of our practice. The second expert is Dr. Bharat Saboo. He is a diabetologist practicing in Indore. He is a director of Prayas Diabetes Center. And he has completed scope certification for obesity management. In addition to medicine, he has a keen interest in artificial intelligence, machine learning, and data science. And we were just discussing that why you are pursuing that. And he said that this is going to be the future of medicine. And so he's also trying to learn all this and integrate that into the practice. Now, before we enter into the interaction, I would just like to say something about the disclaimer that the aim of this webinar is to give you information. But before you implement these information into your lifestyle, please ask your doctor, your physician to guide you about using this treatment or this discussion which we are telling you. OrthoTV, Dr. Urman Dhruv, Dr. Bharat Saboo, or I are not responsible for any of the complications which arise out of using this information into your practice. So with that disclaimer, we go on for the discussion. If you have at any point any question, please feel free to WhatsApp me on my WhatsApp number. I'm giving you the number. Please note down. It's 97129 25600. I repeat, 97129 25600. So with that, we start our interaction. And the first question which I'm going to ask is to Dr. Dhruv. Can you tell us about obesity? What is obesity? Because a lot of laymen are also watching this webinar because of the interest in this topic. So can you briefly tell us about what is obesity and why it is important to understand about obesity?
So let us start with 3 idiots. First of all, thanks to OrthoTV team and Dr. Dhiren. So let's start with 3 idiots. There are 2 definitions of obesity. One is Chatur's definition and second one is Rancho's definition. So what is Chatur's definition? Well, obesity was previously considered to be a physiology. Then it was considered to be a disability. And then we realized that it is a disease. Which sort of disease? It's a chronic, progressive, relapsing, treatable, neurobehavioral, multifactorial disease where there is an increase in the body fat, which promotes adipose tissue, leading to dysfunction of adipose tissue, abnormal fat mass. There are physical forces, and all these result into adverse metabolic, biochemical, and psychosocial health outcomes.
Well, you are absolutely right that it's really a Chatur's definition. Yeah, let's remember the Rancho's definition.
Right. Remember, as we come to know more about obesity, few more words would be added to this definition until we really know exactly what is obesity, when the definition would become absolutely simple. Now let's look at the Rancho's definition, which was actually given by WHO, World Health Organization, which has very simply classified every individual on the earth into three categories: non-overweight or non-normal, overweight and obese, depending upon the BMI. You all know what is BMI, body mass index, which is height in meter square, weight in kg upon height in meter square. That gives you BMI. So a BMI less than 25 is fine. For the Asians, BMI below 24 is fine. Overweight is 25 to 29.9. So below 30 is overweight, and above 30 is obese. So anyone having BMI above 30 is obese. So simple. Again, they can be divided into grade 1, 2, 3, 30 to 34, 35 to 39, and above 40 would be morbid obesity. Why this is not very acceptable medically? Although, remember, this is at present the only universally acceptable definition of the obesity upon which all the trials are being carried out. However, there are large individual variations in body fat for any given BMI. So at BMI 25, 2 persons can be different, which is known as YY differentiation. So it may varies with the sex, ethnicity, age, and that's why BMI, although we are depending upon it, is soon going to change. There are other methods to measure obesity like waist circumference or waist hip circumference ratio, etc. But we'll stick to BMI. Coming to another important thing in a couple of statements, and that is the visceral versus the abdominal obesity. So the subcutaneous fat which is getting deposited is something that we routinely see. And I call all my patients that there are actually 4 types of fat in the body. One below our skin, which is practically not very significant. Second, which is moving around in the blood, which we call as lipids or cholesterol. Third one, which is getting deposited inside the walls of blood vessels, which we call as atheroma, which is the most important, more important for diabetics. And the last one which gets deposited in the viscera, especially liver. And accordingly, they are known as visceral fat. Again, one more classification where I land, and that is white fat or white adipose tissue and brown adipose tissue. These are the things that we have recently learned in last 5 years, and they actually create the whole problems as far as our obesity or its health consequences are concerned. So this is probably everything that we need to know about obesity as far as definition is concerned.
Just another question in the same direction. Like in your practice, how common is the obesity? Like say you see 100 patients in a day, then how many patients would be obese?
So basically, it is a rapidly escalating public health issue. At present, there are 650 million obese person. Obese meaning here, I mean that obese is BMI more than 30. I'm not talking about overweight. 650 million people across the world are obese. But as far as the Indian practice or our practice is concerned, once again, you can divide obesity into 2. Obese children, which is the most worrying portion. And fortunately, we did a couple of studies in school children, and where we could find 1 out of every 5 children was obese. 1 out of 5. So it is 20%. As far as the obesity in our population, patient population is concerned, out of 100 patients that we see in a day, about 60 are overweight, about 50 or 45 are obese. Out of these all obese patients, 40% are diagnosed, which means there are, for every 1 patient that we see as an obese patient, there are 3 other more obese patients, not obese individual. Obese patients are moving in the society. Out of this 40%, only 20% reach a doctor. And out of these, only 10% receive the really evidence-based medicine. So if I see 45% of my patients, 45 patients out of 100 as obese. That means about 450 obese patients are moving in the society. And that itself says how difficult it is to diagnose, treat, and evidence-based treatment of obesity.
What you said is absolutely right, and I fully agree with you. Like, say, my practice is pediatric orthopedic, and I see children, and in my practice, one third, approximately, I have not gone for any study, but my rough imagination is like 30% of my, sorry, one third of my patient are overweight or obese, and that really make me to worry that if they are obese or overweight at this young age, what is going to happen in the next 20 years or 30 years down the line. So let's understand the worry, like why we really need to worry about obesity. Fine, people are going to carry their weight, but then why we are really worried about that? Because as Dr. Urman Bhai said, that not every obese patient turns to medical care. Then why, as a doctor, we are so much giving importance and emphasis on overweight and obesity? Yeah, Bharat Bhai.
So we need to worry about obesity because it is very easy to say that people seldom seek advice for obesity, but obesity is a precursor of so many disorders. Previously, we used to thought about what is causing all these things. And as Urman sir has rightly pointed out, we actually are a population of thin fat Indians, where we look thin, but we have a lot of visceral fat around us. So this visceral fat is also killing us. Now, what obesity does is three-pronged. First, the impact is metabolic, which we all are aware of. It disturbs the metabolic milieu of our body, and it causes so many things like hypertension, dyslipidemia, type 2 diabetes by causing insulin resistance. Then we again have various sort of thrombosis also now, which are attributed to obesity. Second is mechanical. So as an orthopedician, you will understand that this mechanical aspect is very important, because once we are not able to move due to obesity, due to heavy weight, because it puts so much pressure on all our body systems, we are not able to perform activities like we should, then it again impacts all of other body functions. It causes knee osteoarthritis as well, which is a mechanical component. And again, gout is there, which is again attributed to obesity in many patients. Chronic back pain, the disc pain never goes for an obese patient. So these are the mechanical aspects. And the third very important point which we should worry about in our kids, as Urman sir was pointing, is the mental aspect. We have done a study, we have done a lot of work on this mental shaming of diabetic and obese children. And we were surprised to see that depression scores were very high in the children who were obese, who were having a thin fat around their body. They were very, very mentally disturbed. So all these factors are there because obesity, although it may not look like a disease, but it is precursor to so many diseases. It causes sleep apnea, which again disturbs the metabolic milieu. We have HFrEF, which is there, which is for common man, which is a heart failure with reduced ejection fraction, which is there. And above all, the NAFLD, fatty liver, which everyone is now talking about, is again a result of obesity. So all these things are actually caused by obesity. And if you put on paper, out of 90% of our worries, out of 100% of our worries, 90% are caused by obesity itself. Secondly, why we need to worry about obesity is life expectancy. If we are able to cut down our BMI, let's say when we have a BMI which is normal, the study shows that we have a 80% chance of reaching age of 70. But if we have a BMI, let's say up to 40, 30 to 40, our chances of reaching age of 70 becomes 65%. And if we have a very morbid obesity, a BMI more than 40, our chances of reaching age of 70 becomes just 50%. So this is one way where we should look at it. If you want to live longer, if you want to live healthy, we need to tackle this obesity as soon as possible. And that is why I think it is very important to talk about obesity, first of all, to everyone, because unless we talk about it, people will never know about it. People will think, khate pite ghar ka hai, isliye mota hai. So this is not the thing, because to all those people who are not doctors and listening to it, every person who is chubby is not good. And being chubby may look good, but internally it is not absolutely doing right to your metabolic milieu. Vice versa, when we reduce the weight, a 10% reduction in weight can do the diabetes remission. And when we reduce the weight by 15%, we can even reverse the HFrEF. Heart failure is sometimes reversed. It is shown in some studies. So just by doing this much to your body, just by reversing this obesity by 10-15%, we can do so much good to our body. And that is why I think obesity should be tackled very strongly, even at the level of childhood, because that is the point where we can tackle it most easily. Our joints are most supple, we are most active, and we are most obedient and have time to follow the things.
Yeah, so that's very true that obesity affects to a lot of system. What about the cancer? Does it cause cancer?
Yes, sir. It is again being shown and postulated by studies to cause cancer even. And it actually increases the recurrence of cancer if the patient is obese. So once you have a cancer cell in body, if you are obese, then your metabolic milieu supports for the growth of cancer cells.
So over and about the problems which you mentioned, there is another problem which directly or indirectly affect the longevity of the patient. What you said that your chances of reaching 70 years gradually go down. So one of the possibility is that it's via cancer, it's reducing the longevity of the patient. That is
It can be anything. It can be a stroke. It can be MI.
yeah. But one of the reason could be cancer also.
Is the most dreadful thing, because what we are doing, we are making our metabolic milieu favorable to any abnormal cell to flourish upon, and that is how cancer occurs. And it has been shown and it has been postulated in studies that those patients who are obese have a high recurrence of cancer, have a bad survival when they have developed cancer, and to a surprise to many, overfeeding has also been linked to many cancers. While we think that overeating is good for us, and if we are not eating, we are not healthy. If we eat less, if we reduce our calorie intake by say 30%, our chances of living more than 70 rises. So this is a paradox to what we are taught actually over the years.
Yeah, like coming to the same question, Urman bhai, Dr. Saboo mentioned about some of the reason khate pita ghar ka ladka hai or overfeeding and all that. What is your understanding that why society is gradually like I remember that before 30 years, people were not so much overweight or obese, like the incidents which we see in the recent years. So what has happened in last 2 or 3 decades, which is responsible for this problem?
Again, we have two sorts of explanation, Rancho's explanation and Chatur's explanation. So Chatur's explanation would be lots of factors like physiological, psychological, genetic, environmental, socio-economic and environmental causing a lot of behavioral changes. But to summarize, in Rancho's words, it is seed and soil theory. So, किसी भी पौधे को पैदा होने के लिए बीज की जरूरत है, सूर्य प्रकाश, खाद और पानी की जरूरत है. उसी तरह से, just as for an obesity to occur, you require seed. Unfortunately, genes about which we have no control, and most of the Asians do have the obesity genes. About 300 loci have already been identified, and the studies carried out in twins and families have shown that obesity runs in families. But more importantly, those families who do not run are more obese than those families who are already obese. So it is more or less environmental factor, that is Surya Prakash, Khad or Pani. And how do we pour on it? Very easily. Before 30 years, we were hardly eating once or twice outside our home. These days, especially the kids below 25, and all those who are listening to today's talk, please carry this message to your next generation. If you belong to my generation, to your next or the third generation, that whatever you want to do it between the age of 15 and 25. So we were hardly moving to a hotel once in a year or twice in a year. Now the children are eating at home once or twice a year. Every time there is a problem about taxes, we give more significance to वो multiplex में popcorn का भाव कम हुआ कि नहीं हुआ. We are worried. उसकी size कम हो गई because we need a big size. Pizzas have become big. Everything the portions have become big. Previously, we were using to play outside our home. Now the children have to be thrown out of the home if they want to play there. And there are no playgrounds. So we are becoming sedentary. We are sticking ourselves to the social media, mobiles. That is one important issue. Behavioral issues. What are the behavioral issues? I can remember a very important dialogue of Amitabh Bachchan's film. Dhiren bhai might think कि मैं बार-बार movies लेके आता हूँ, but that is something to which we are more connected. There was a dialogue in film Diwar for drinking. कोई इसलिए पीता है कि चलो आज बहुत थक गए, कोई इसलिए पीता है कि आज कुछ काम नहीं किया, बोर हो गए. Exactly the same situation is happening for eating these days. बहुत काम किया, चलो बाहर जाके पार्टी कर लेते हैं. आज कुछ नहीं किया, चलो बाहर जाके पार्टी कर लेते हैं. So that behavior. And the worst thing that is causing obesity is we are not counting our calories. We are not understanding how much are we eating, especially when we are eating outside, in parties, or when we are eating sitting in front of a television. We go on pouring in our mouth. So food intake and energy balance. It is the simplest thing about becoming an obese person. The energy that you are taking inside is much more than the energy you are actually needing. And that is what leads to obesity. So if you want me to realize how people are becoming obese, because now they are not counting the calories, they are not spending the calories. That is the most important thing that is causing obesity. Otherwise, as I said, there are socioeconomic factors. Previously, it was believed that obesity is a disease prevalent in the developed countries. Of late, within last 5 years, all the obesity has actually entered into the developing countries. And we now see even poor people becoming obese. There are now theories which suggest that the starvation in utero and abundance in the life, which means a female who becomes fertile, conceives, and during that time, if she does not get proper nourishment, which she cannot transfer to her child or the fetus in the womb, that leads to malnourishment in the fetus. And the same fetus, on arrival onto this earth, starts getting abundance. That leads to insulin resistance and obesity. So both the things are bad. If you want to have a non-obese world, first and foremost thing is you must have a well-nourished mother. And number two, first 5 years or 7 years of the life, you should not start pouring in abundance to the children. So that's how we are becoming obese. Otherwise, there are so many reasons, socio-economical and behavioral, where there are lots of reasons. As I said, the food portions to the exercise, everything.
Yeah. What Dr. Saboo do you think about Dr. Urman Bhai said that he said that we need to nourish mother well. Fine, that's true. That's we are taking care of the problem from the inception. But if we really want to do something to the people whom we see, what options do you use in your practice?
But it's very simple. Actually, all the philosophy regarding the maintenance of weight lies around intake and output. So we need to teach everyone, and we preach this, that your intake should be less and your expenditure should be more. This is a simple dictum in the energy mechanism of body. If we are reversing it, we are bound to get obese, because this is body's response of extra calories that it deposits in the form of fat itself, nothing else. So the only thing by which we can prevent ourselves, our future generation, and our patient and friends, everyone, is just by either increasing the expenditure, which I don't think with urbanization is no more possible, because now we have a two-wheeler to go to next door shop, and we seldom walk, which we previously used to do. Urman sir and you must have driven a lot of bicycle. I have driven enough of bicycle, but my kids don't drive bicycle. So this is again a shift. Secondly, you have not been having the legacy to eat a samosa in a month. I had a legacy to eat in 10 days, and my kids are eating daily. So we are shifting ourselves from a energy expenditure environment to a energy taking environment. We are taking more of the energy than we used to spend. Now the whole problem lies around our psychology, and that is what is needed to be corrected first, and which we and in our center try to do. We try to give them out all those things, how this energy comes and energy goes, and at all in patients where technology can help us, it is proving to be very beneficial to patient. The only way we can avoid obesity, I am telling you, not treating obesity, avoid obesity is by maintaining a healthy diet and a optimum balance of exercise to counter that diet, so that we can burn all the energy, take up the micronutrients, and we live happily, healthily. Because the food we eat is not only for energy, it is for micronutrient as well. Some people do a crash dieting, which is not good, because by doing crash dieting, they deprive themselves of so many micronutrients. This is again bad. So there should be a balance of everything. We need to balance our food, and as it is rightly said, जैसा आहार होता है वैसे ही मन होता है, जैसा मन होता है वैसे ही कर्म होते हैं. So it all reflects in our actually disease profile as well as our mental health and everywhere. So the first and foremost thing is maintaining a logbook, a record of what we are eating, how we are eating, and when we are eating.
Okay, just let me have a quick question. If you have tried this strategy with your patient, how successful you are in this strategy? Are patients able to calculate? Because it's extremely difficult to calculate calories every day. Like I ate 100 ml of dal, 100 ml of 100 milligram of rice, and then to calculate. Yes, there are few apps available, but is it really practical?
Apps are really tricky, sir. What we do, we give them a thali and vati and glass. We give it from our end, and it is all calculated. Vati is 150 ml katori, which we give. A thali, small thali of 9-inch diameter, and a glass having a 200 ml capacity. We give it to every one of our patients. We just ask them kitni khai wo likh ke le aana. Then our people will do the things, and we just put it in the Excel sheet, and everything is done. So this is a very simple tool which we have devised for our obese patient, where we want to give them a feel of how much they are eating, because this is only required for initial 15 days. Once 15 days are gone, we see either the patient is interested or he becomes utterly disinterested. I tell you very frankly, and he even may not come to me because he don't like counting his food. So those who are motivated, we are happy, and we are with them, and then we work along.
Okay, thank you. So now we are like entering into the main topic, and that's about the medicine. So first of all, let us see the past before we discuss about the recent medicine. Dr. Urman Bhai, can you tell us about like what medicines have been available to us for reducing weight, and what were their problems, and why we are looking for the new medicine, which we are going to discuss just now. So can you tell us something about past?
Yeah. As Dr. Dhiren has already suggested, that whatever information we are giving about medicines should not be utilized without the treating doctor's advice. So that is always a disclaimer. Number two, no medicine can replace diet and exercise, your behavior. So that is also equally important. Lifestyle changes is a must, and then comes medicine. So since 1999, the first and the foremost medicine that was available and still continues to remain available is Orlistate, which is actually a pancreatic lipase inhibitor. The drug is still working. It is still useful for those who are having excessive fat intake. How does it work? It prevents the absorption of fat. What are the problems? Simple, it causes fat leaking. So it becomes very embarrassing for the person. There are sticky stains on your pants, etc., because the fat that you excessively take would not get absorbed and would leak. And that's the reason that the drug went into the forgetfulness, and people lost the memory of the drug. But even then, till today, those patients who are taking excessive fat, we are still using Orlistate once in a while to prevent them to take the fat, excessive fat. And this is as good as giving Metrogyl to people who are taking alcohol. So this is a sort of antabuse-like reaction when you give the Orlistate. It's generally being taken 60 milligram 8 hourly or 120 milligram with each major meal. Then comes a combination of drug that was naloxone and bupropion. Again, these two drugs work basically on the central nervous system, reduces the appetite, and bupropion works on basically dopamine and noradrenaline. Practically, actually, they are working in the same way as GLP-1 receptor agonists are working, but unfortunately, these two drugs had been causing a lot of constipation, headaches, vomiting, severe dizziness. People do not like taking them. They cause severe nausea and dry mouth, most of cholinergic side effects. They can cause even retention of urine. Many times they can cause seizures. And that's how they have been now forgotten. And we do not use most of the time these drugs. They are better avoided. The next group of drug is phentermine and topiramate. Once again, these are the drugs that were being used for some other purposes. We tried it in reducing the appetite, causing the satiety. The drug worked really very well. But then came the data about its cardiovascular safety. We realized that they can cause the increasing heart failures, arrhythmias, and that's how the drug was again forgotten. This group of drug was forgotten. They can also cause cognitive problems. Then comes the liraglutide, the drug that which we have been using now for a long time. Actually, most of the anti-obesity drugs were initially claimed to be utilized for diabetes. Same was the case with liraglutide. That was actually a drug for diabetes, and then later on in higher doses at the dose of 3 milligram. For diabetes, the doses were actually 0.6, 1.2, and 1.8 milligram pre-filled syringes. But then for obesity, that was the first drug which was approved injectable for obesity at the dose of 3 milligram. And it is being utilized a lot in Europe these days as an anti-obesity agent. Problems, very minimal. Number one, injectable. Number two, being a GLP-1 receptor agonist causes nausea, vomiting, and probably a little more than the rest of the newer GLP-1 receptors that are available. It has got CV safety. It's in fact has CV benefits also, but it can occasionally increase the retinopathy, not as bad as the rest of the GLP-1 receptor agonists, but it can cause the medullary thyroid carcinoma, so should not be utilized in patients having history of medullary carcinoma, even in the families. However, still, if I'm given a choice, if no newer drugs are available, I would still continue to use liraglutide. But unfortunately, better drugs from the same classes are available with much more safety and much more efficacy. Liraglutide was reducing the weight by 5%. Now we have got drugs which are reducing the weight by 15% with equal safety. And that's why liraglutide at present is still being utilized, but would gradually go into the past once the newer drugs are being available. Couple of more drugs before I end. Setmelanotide, it is another drug that is approved especially for pediatric obesity. The drug can be used at the age of 6 years or more for pediatric obesity, but it is only utilized in monogenic form of obesity because the efficacy is very selective. Again, it is being injectable, so local site reactions are more, skin hyperpigmentation may be seen, there is headache and GI symptoms just like nausea, diarrhea, but the drug is only to be utilized for monogenic form of obesity, which is a genetic form of obesity. The last molecule on the horizon that is being utilized, and we all are using a lot, is semaglutide, injectable and oral. And look at the globalization. The first molecule in the world, injectable semaglutide, it never came to India. How fast Indian economy is working. Oral semaglutide, as soon as it was launched, it has started becoming available in India. So we are the luckiest of those countries where the oral molecule has been available even before the injectable one, and oral has practically the same efficacy, 5 to 7.5% reduction in weight. Oral tablet, it has to be taken in a particular way, which requires specification, and that's its drawback. It has to be taken early in the morning with minimum water as possible, but never more than 120 ml. That is never more than half a glass of water. Nothing, no tea, no milk, no food, nothing for next 30 minutes to 45 minutes, no drugs even, especially the thyroid molecule. So all drugs are to be displaced for an hour. So that is something that is important because this is a peptide in a pill. And as Dr. Bharat Bhai was talking about, AI is going to be the future. Actually, it is a future. 5 years back, me and Bharat Bhai were giving lectures that you will never get GLP-1 receptor agonist orally because they are peptides. They get destroyed immediately by acid in the stomach. They require to be absorbed in the intestine. But technology has made it possible. And now there's a long list of drugs that are coming. So semaglutide, what is important about semaglutide? The dose that we are using in cases of diabetes is maximum 15 milligram. But now 50 milligram semaglutide is being utilized in obesity. Multiple trials have come and probably it is also going to be a future drug for obesity. Then there are multiple drugs, different drugs like lorcaserin and whatnot, but they are not being utilized and they will never come into the effect. However, as I told you, there are multiple molecules which increase the obesity, which increase obesitogenicity, and there are multiple areas. SGLT2 inhibitors were there, but they are not very effective modes to reduce obesity. But then there are multiple molecules which are being targeted at this juncture. The one that we are going to talk more in details would be there, but that is also becoming the present. The future is coming very soon in the form of triple hormone agonist, and that we'll talk later on. So this is the past of anti-obesity drug. None of them has survived except liraglutide and probably semaglutide.
I fully agree with you that when we have a lot of medications, the common or the general rule is that none of them is really working well. Otherwise, like company would not bring the new molecule. So on one side, we have a big problem. And the medicines which you described has an efficacy of 5 to 6% weight reduction, which is not really enough looking at the obesity or the BMI of 30 or 30 plus. So we have a new molecule. So the name of that is Tirzepatide, right? Or like, how do you pronounce it?
Tirzepatide. But before that, Dhiren bhai, the reason why all these molecules were there was we were understanding, as Bharat bhai rightly said, that 5% reduction was considered by WHO to be at least bare minimum. And that's why these drugs were considered to be efficacious. Once the direct trial came and we realized that 15% reduction actually completely reverses the diabetes or remits the diabetes for a short duration. So we started understanding the significance of higher amount of weight reduction, and so came the newer molecule.
Right. So, Dr. Saboo, can you tell us something about the new molecule which is going to be launched recently in India, and what are the trials available about the molecule? So just about the history of that molecule.
You are muted, Bharat bhai, you are muted.
Extremely sorry, sir. Sir, as Urman Bhai has rightly pointed out, avashyakta hi aviskar ki janni, and that is what has paved the way for Tirzepatide, because we were very happy. 5% weight reduction was what we wanted, and we were, Urman Bhai knows it, 5 years back, we were posting 5% is too much, we can remit the diabetes and blah, blah, blah. And then suddenly direct trial came and it showed us that 5 is okay, but if you do 15, you can reverse heart failure even. You can do so much good to the metabolic milieu. And then, as human tendency is, we humans are tireless and we keep on working to develop newer and newer things. And that is what has paved the way for this beautiful molecule, because then they thought of, if one receptor can do this, what about two? If two receptor, they give the effect, then what would be the beneficial effect on the metabolic milieu of the whole ecosystem of body? And that is what gave rise to the molecule which is we know as Tirzepatide, because it is actually a dual novel sort of dual receptor agonist, which acts actually on it's again a peptide. It's act on two receptors, GIP and GLP-1. So what it does, it actually a single molecule which is targeting two things, a GIP and a GLP, which we previously used to do with two different things. Now we are killing with a single bullet two people in simple language.
Just to interrupt, the audience would be many orthopedic surgeons. So can you tell us about GIP and GLP? So just brief background and then you describe the mechanism.
I'm just coming on that, sir. I'm just coming. So let me just do this, and I'm just coming on to it. Now what happens? This is an interesting thing, because then they thought about the half-life of it, and then they came to know that regarding the history, the half-life came out to be around 5 days. And what was most prompting was to see that if we give it once a week, it will do wonders. So these two hormones, which is GIP, which is known as gastric inhibitory polypeptide, or glucagon-like peptide 1. This is GLP-1's full form. So these two molecules can be hit with a single bullet in just once a week regime. So this was the most beautiful aspect of this molecule. And secondly, they were beautified to see that renal and hepatic impairment doesn't impact this. So this can be given to a wide range of subset of patients. And actually, this actually what it does, GIP and GLP-1, what they do, both when we tackle both of these, they increase actually the beta cell mass as well, which is never been thought of, which increases the beta cell mass. It improves the insulin sensitivity. That's why it increases or it maintains the glucose homeostasis, because most of our diabetes revolve around insulin resistance and the beta cell depletion. These are the two things which happen to a patient. या तो insulin resistance होता है या beta cell कम हो जाते हैं. So this actually what paved the way for further work on this molecule, and people were people became Eli Lilly somehow company, sorry, but it became interested in working on this molecule. And then they saw the homeostatic model for insulin resistance and the beta cell function. And they came to know that it is dose dependent. Once we increase the dose, it works much better. So they started doing trials with 1 mg, as every trial is done with a minimum dose. Then they increase it to 5, 10, 15 till they go. And till 15 they went, and then they found that there is a dose dependent decrease in HbA1c. Now, what was surprising to see was there were some actions which were GLP agonist dependent. There were some actions which were GIP agonist dependent. Like GIP, it actually controls our food intake. It controls the nausea, and it also increases the energy expenditure. So these are GIP mediated activities. We have been taught this in physiology since day one. And what GLP-1 does, it causes satiety. It is opposite of food intake. It causes satiety. And then it again impacts food intake by that, and it decreases the body weight. So these two, when they are combined, they give certain effects. But what was surprising to see was there were some effects which were not of GIP and GLP. They were independent effect, which is a third class of effect which this molecule has, because then it again decreases the hepatic glucose production as well. So people are postulating can work very well in NAFLD also. It increases the skeletal muscle insulin sensitivity also, and it reduces triglyceride levels also. These all are indirect actions which are not dependent on GLP-1 and GIP. Now, regarding trials, there has been a subset of trial on this molecule, which is Tirzepatide, and it has been shown efficacy across a continuum or gamut of trial, which we know by the name of SURPASS. So in SURPASS, actually in SURPASS 1, what was done? SURPASS 1, I just tell you in brief. There were SURPASS 1, 2, 3, 4, 5, and 6 is there also, which is ongoing. So SURPASS 1, they tested this molecule with a placebo. In SURPASS 2, they tested it with a benchmark, which is semaglutide. As Urman Bhai told, at that point of time, semaglutide was a benchmark, and it is still a benchmark in India. So they tested it with semaglutide. In SURPASS 3, they tested it with insulin degludec, which was there, which was again a molecule which was there, and it was postulated to reduce weight, and it reduces weight also. Then in Surpass 4, it was tested vis-a-vis insulin glargine to test its glucose lowering efficacy. In Surpass 5, it was again tested against placebo, just like Surpass 1, but with insulin glargine. So insulin glargine and placebo, it was there. And in Surpass 6, it is undergoing with insulin Lispro, the shorter acting version of the insulin glargine, the insulin. Now, what it has shown that it is having a phenomenal result across all the Surpass trials. And the impact is dose dependent. And people were surprised to see the change in HbA1c, which was again dose dependent. In all the Surpass trials, it was reducing HbA1c somewhere in tune of around 2.5 to 3. And the weight reduction was again phenomenal because it was able to reduce weight up to 25%, leave 15% aside. 25% was the weight loss which was achieved, and it was recently presented in the ADA this year, just 15-20 days back. So with the HbA1c reduction of 3% and a weight reduction of 25%, this molecule will surely change the way we practice metabolic medicine. I'm not talking about diabetology, I'm not talking about obesity. It will surely change the way we are tackling the metabolic burden, because there is a recent study which shows that 80% of our patients are having dyslipidemia, 50% are pre-diabetes, 40% are obese. So it is a molecule at the opportune time for Indian people, actually, because we are currently dealing with a population which is actually dealing with so many problems which are arising out of obesity. So all these trials, sir, have definitely shown and proven its efficacy in both, although it is a medicine which is approved for type 2 diabetes mellitus first, and it has shown its impact to reduce the obesity burden as well.
Okay, so Urman Dhruv, what do you think about the results which Dr. Saboo already described, that 25% weight reduction, which is phenomenal? I would say that it's going to be a game changer. What are the results which were published in all these trials? Do you think that these are for the Indian population, or for Indian population it will be different? Do you think so?
I'll go in very nutshell because we may be running short of time. So 5 important things. A Surmount trial which was done more in obese patients, where all the diabetic patients were excluded. Pre-diabetes and obese patients were only included. Let's look at the results of those only, because we are not much worried about diabetes at present, only talking about obesity. So Surmount trial, where the molecule was utilized in patients having pre-diabetes or obese. Now look at the results. The trial was of 72 weeks. So it is practically 1.5 year long trial. That is the most important thing. So it is not a trial of 16 weeks or 22 weeks or 24 weeks. It's a very long trial where 3 different doses of the Tirzepatide was compared with placebo. Number 2, all the patients underwent enough behavioral and dietary counseling, and 500 calorie reduction was advised to their current diet. So all, including placebo, had a baseline dietary and exercise protocol. So this was over and above the diet and exercise. And that is very important in non-diabetic patients having pre-diabetes. And what were the results? The results suggested that 85% of the patients had at least 5% reduction of weight. Well, that's not very significant, one would immediately say. Those who had more than 15% weight reduction, the number of patients or the percentages of patients was 35%. As far as the lowest dose of Tirzepatide is concerned, and with highest dose of Tirzepatide, that is 15 milligram, the reduction of body weight went up to 20% in 65 or more percentages of patients. So most of the patients showed the reduction of weight by 20%. Now look at the few characteristics of the patient. What was the average weight of the patient? 108 kgs, average weight. And they reduced to 80 kgs or 85 kgs. at the end of 72 weeks. The weight reduction started at the end of 12 weeks and persisted up to 72 weeks. Important. Number 2, they were non-diabetic. And number 3, the weight reduction was seen irrespective of age, irrespective of the sex, irrespective of ethnic changes, because the trial was carried out in multiple countries, including few Asian countries. So nothing to do with the ethnicity, nothing to do with age, or nothing to do with sex. The results were equal at all ages and in both the sexes and in all geographical distribution. And that's why the trial holds lots of significance. There are lots of plus points of the trial, but we don't have enough time. So the most important outcome was not only the weight reduced, the weight-related complications like cardiometabolic risk factors, CRP reduced, systolic blood pressure reduced, heart failure reduced, the walking distance improved, the parameters like lipids improved. So not only there was a weight reduction, there was reduction in all cardiometabolic risk factors. And that's why after a long time we have seen, I would say for the first time we have seen one molecule which has been working for 72 weeks and not only reducing the weight, but reducing the cardiovascular outcomes also. And that's how the drug is very significant.
Fine. Urman Bhai described a lot of plus points, like it worked in 2/3 of the patient at the maximum dose. And at the lowest dose, that's a 5 milligram, it worked in 1/3 of the patient. And the amount of weight reduction was 5% to 20%. So that is the most important thing. I'm always concerned about the side effect, because if you look at the past, all this medicine have some or the other significant side effect. And when some new molecule is presented to us and with the impression that there is no side effect, then I always doubt about the efficacy. So just Dr. Saboo, what are the side effect, likely side effect in all this Surpass trial people have observed?
So actually these are side effect, but these are physiological effect, because this is a physiological molecule.
Yes.
So it causes this physiological effect, which actually becomes side effect to patient. It doesn't cause overt side effect. It causes, because it reduces appetite. So it causes a feeling of decreased appetite, which is there in around 5-7% of patients, which is very normal because it is a GIP GLP-1 receptor agonist. The most common side effect is nausea. The patient feels nausea. And it is a very common side effect, very common because it is up to a tune of 15% in patient, 15 to 17% of patient report it. And it is at 5 mg dose. When we increase the dose to 15 mg, it is up to a tune of 20-25% nausea in patient. Secondly, diarrhea is also very common. The second most common thing is diarrhea, which we frequently see in the papers which are there. And it is up to a tune of 13 to say 18% of patients which will be having diarrhea. A decreased appetite, as I have told you, is accompanied by dyspepsia also. Patient does not feel well, and there is a dyspepsia in patient up to a tune of 7 to 10% of patient feel this. So most of the side effect, almost all the side effects which are there are related to gastrointestinal system, because that is the prime mechanism where these two molecules work. Along with it, there is a very fair percent of patients which have abdominal pain, which I have although not used it, but by my experience from semaglutide, which is due to blotting and all those effects, which is due to the blotting effect, which is there with these sort of molecules, which are having a GLP-1 receptor agonist effect. And this is due to that. But surprisingly, what was there to see, as the therapy goes on, these side effect goes down. And this is what has been seen and presented multiple times in ADA. Since past 3 years, they are presenting that data from Tirzepatide, and they have shown that once the therapy duration crosses 8 weeks, the patient becomes comfortable with Tirzepatide. The side effects becomes much less, up to a tune of just say 2-3%. From 15-16%, it comes down to a tune of 2 to 3%. So GI tolerability actually improves with time, which is again a thing which people are working upon, why it gradually improves. And again, there has been no episode of overt hypoglycemia. because people have not been able to document it at a higher dose. The only single incidence which I can remember was with the 5 mg dose, which can be by a chance, which was not statistically significant. And actually, there is no adverse effect which lasts longer than 8 weeks. The effect which are there are up to 8 weeks only. If the patient is able to tolerate it up to 8 weeks, then he's free to go with the molecule.
Okay, just a short question. How many patients has to stop medicine because of the side effect?
In the study, actually, if you look at the Surmount study, which was done on obese patient with 5 milligram, and that's a very valid question, because the discontinuation or the fallout is considered to be the most important thing. So it was with 5 milligram, 4.3%, and with 15 milligram, 6.5%. With placebo, it was 2.6%. So very limited fallout of the patient in the trial. Coming to the people who are taking it, we have hardly seen a single patient missing the doses, at least for first 2 months that I have seen. So practically to me, the side effects are negligible. If you explain to the patient initially that nausea and postprandial heaviness are going to be there for a few weeks, then they accept it, because the weight reduction starts very rapidly.
Okay, so once they start seeing the effect, they are motivated to continue with the medicine and they are ready to accept some of the side effects. Fine.
And these are all subcutaneous injections to be taken by the self. Very easy to take, prefilled syringes.
Yeah, perfect. So let's hope that this molecule is not at present available in India. So when it is likely to be available in India? Urman bhai, yeah. Any idea?
It should be available within a couple of months to 6 months officially. Otherwise, online, there are pharmacies which are providing you at the rate of 10,000 to 25,000 rupees. But you have to be very, very careful. Actually, it is not legal at present to get it online, number one. And couple of my patients have been, actually, there are frauds where they got something else at the cost of 2,000 rupees. The molecule was supplied and it was never Tirzepatide. So I would not suggest to buy it unless there is an authentication. But yes, it is available online at 25,000 rupees or so. But within 2 to 6 months, it should be available, because India has got a very huge market.
Right. So I'm going to ask this question to both of you. Like, suppose the price is acceptable, means like within the limit of most of the patient. How or in which patient you are going to start this molecule? Because as you said, 40% of your patient or 60% of your patients are overweight and obese. So today is July. Let's say in January 24, the molecule is available with you with a reasonable price. Are you going to prescribe this molecule to each and every patient coming to your practice? Dr. Saboo first and then Dr. Dhruv.
Sir, every molecule cannot be prescribed to every patient, first of all. This is a simple philosophy when doing practice in India, because in India, practice is governed by so many factors. The most common factor is socioeconomic. And it always hurts a patient if we are prescribing him a molecule which is beyond his capacities. It more than hurting him metabolically, it hurts him mentally as well. So I, in my practice, being very cautious about this, I will like to prescribe this to those subset of patients who are willing to, first of all, willing to reduce weight. They are willing to reduce their calorie intake by 500 kilocalories, as Urman sir rightly pointed out. The beneficial and most beneficial effect comes when we reduce the caloric intake also along with using Tirzepatide. And thirdly, he has a capacity to sustain this molecule for, let's say, 72 weeks, because that is the point where we will get the maximum benefit out of this molecule. There is no point in starting a molecule for a heroism for 2 months and boasting around that I have 100 prescriptions of a molecule when we are not able to do any good to a patient. Last, I think as a doctor, it's my duty to inform each and every patient about this molecule. So I will definitely try to inform each one of them that if this is a molecule which is available, there is such thing. Then ultimately it is wish of patient. If he is wishing and willing to go, I think 40% of my patient lot would be eligible to have a Tirzepatide.
Okay. And Urman bhai, before like you answer this question, I would like to add one more question. What happens to the patient after 72 weeks? Do they have to continue the molecule or they have to stop it? And if they stop, what happens to them to their weight? I know that these are like early questions because still we don't have information, but what do you think?
In fact, the SURMOUNT trial is already going on. For those who were pre-diabetes, the trial is going on. For those who were only obese, in those cases, they have continued the molecule for 2 months and then they have stopped it. And they are waiting for 1 year result. The first 3 months result are same. The weight addition has not been seen, provided diet and exercise have been continued. But these are only 3 months result. Coming to the weight addition would occur or not, probably it may not occur. You may continue the molecule for a longer time. 72 weeks is only trial, but the molecule can be continued for a very long time because basically these are all hormones produced by the body. These are not actually the drugs, just like thyroxine. This is a molecule or the hormones that are being produced by the body, but they get degraded in the body very soon, within 2 to 4 minutes, which we are supplying from outside. So hopefully it should not have any adverse effect, even if they are used for a longer time. Coming to the group of patients that I would like to utilize, I would divide into 2 parts, diabetic and non-diabetic. Non-diabetic obese patient, we can offer this to all the patients who can, as very rightly said, first and foremost thing, the molecule is not to be taken for 2, 4, 6, 8 weeks. So only if you have capacity or budgeting for 72 weeks, start it because the highest advantage available is at 72 weeks. So that's the first thing. Second important thing is all those patients who have struggled hard to reduce their weight, which means they are already motivated. They have done every possible thing except for bariatric surgery. If they've gone for everything, and if they are willing to go for bariatric surgery, I would give this molecule before bariatric surgery because bariatric surgery would be a permanent change. Here it would not be a permanent change. Bariatric surgery option would still remain. So this would be another group of patients who are struggling, making efforts, are already motivated to reduce weight. This is about obese patient. I would not at present use it in patients below BMI 35, right? Because it may be too early, but above 35 we can offer. Coming to diabetic patients, for reversal, because the 15% weight reduction would lead to reversal or remission in diabetes. So in those group of patients, I would utilize the drug only where the diabetes is of a very short duration. There is not already any target organ damage, already established retinopathy, nephropathy, or cardiovascular disease. I don't see much importance of reducing weight because even if you reduce the number of drugs or diabetes may revert, they already suffered a damage. So generally, the results well seen were, as were seen in direct trial, male patients, highly motivated, young patient, type 2 diabetes. Remember, this has nothing to do with type 1 diabetes. So please don't venture in type 1 diabetes. So male, young, short duration of diabetes, not more than 2 or at the most 5 years, and those who are highly motivated and there is no target organ damage. Those patients having with diabetes, these patients with having obesity.
Fine, thank you. So you clarified really like who should be the initial patients, but I'm sure that once we have confidence with this molecule, probably we will extend or expand our indications also. So there are a lot of points to be discussed, but time is running short and we really have to end the session. So I would like to thank both of you. You really gave information in a very clear way so that everyone can understand. So that's very important. And thanks for sparing your time and knowledge with us. And I should also like to thank OrthoTV for giving us the platform so that the correct scientific information can be spread to the orthopedic surgeons, other doctors, and even laymen also. So with that, with the words of optimism, we wish that this molecule can bring some real good change in the society. So thank you very much for joining us. Thank you.
Sir,
Thank you, Dr. Dhiren.
Thank you.
Thank you, OrthoTV. Thank you.